Good evening to all of our viewers. I'm Dr. Apna Rao from the Medical Communications team at DocPlexus, and I welcome you all to a new series. We call it the Flint Shots, your clinical dose of short and focused discussions. These will comprise of 4 to 5 episodes catering to specific health domains for a month. You can watch us live every Tuesday, 6 p.m., exclusively on DocPlexus. Today, we will be talking about early screening of hearing impairment in high risk infants. Hearing impairment affects 1 to 2 per 1,000 newborns worldwide. The hearing ability of infants is essential for normal speech and language development. Considering its importance, conventional and implantable hearing aids and microsurgery are available to treat hearing impairment. Nevertheless, early screening of hearing impairment is crucial to diagnose the condition and make an appropriate intervention plan. Today we have with us Dr. Naina Karotpati. Dr. Naina is a reputed otorhinolaryngologist in Pune. She has special interests in stem cells, endoscopy, teaching, and research. She has been teaching at Dr. D.Y. Patil Medical College, Pune, India, for over a decade. Dr. Naina has also published several articles in peer-reviewed journals and is a reviewer for the WMC International Journal. So without further ado, let's begin our today's session.
Good evening, everyone. On the evening of 75th Independence, I want to wish you all Happy Independence Day. I'm Dr. Naina Karorpati from D.Y. Patil Medical College, Pune. I'm professor in the Department of ENT. And today I want to just share most commonest problem in India, especially in the newborn babies when they are born deaf, and how to screen them at the earliest so that the disability because of deafness can be prevented or taken care at the earliest. So dear all, you know the definition of deafness is total loss of hearing. And when we say it is hearing loss, it can be just partial loss of hearing. And mutism is inability to learn the language and speech and acquire it as near normal. Mutism happens because of deafness. The incidence of permanent bilateral deafness is 2 out of every 1,000 children born. The incidence of severe bilateral congenital sensorineural hearing loss is 4 out of 1,000 babies born. And the progressive sensorineural hearing loss can be up to 15 to 20% after the infancy. So aim of screening the babies at the earliest is to determine if hearing loss is present or not at birth, whether it is bilateral or unilateral. Then we want to know the type of hearing loss and the degree of hearing loss. Whether the hearing loss is prelingual or postlingual. Then we want to establish the topographic localization of the lesion, where it is present from the auditory pathway from the brain to the inner ear. We can look for the other relevant handicap associated with the deafness, and then we have to establish the management protocols. The different causes for deafness, they are classified under the headings prenatal, perinatal, postnatal, and acquired. Under the prenatal causes, they are again subdivided into genetic and maternal causes. So etiologically, the prenatal causes can be genetic factors. This can be syndromal or non-syndromal. They can be dominant or recessive, and they can be X-linked or mitochondrial in cause. May be associated with craniofacial anomalies at times. The different anomalies of the inner ear, they are Stevie's dysplasia, Michel's dysplasia, Mondini's dysplasia. There can be enlarged vestibular aqueduct and semicircular canal malformations. The maternal factors contributing to the deafness in the baby, they are the torch infections in the mother. If there is any history of ototoxic drugs taken during pregnancy, if the mother has got exposure to radiation during pregnancy for any other cause, if there is history of excessive alcohol intake by the mother, if the mother is a diabetic. These factors will add or can cause deafness in the baby. The different perinatal etiological causes are if the labor is difficult and prolonged, if there is fetal anoxia just after birth, or it can be a just hypoxia. If the baby is born with low birth weight, if there are different birth injuries during the partum, if the baby suffers from neonatal jaundice in first 10 days of life, if there is any history of meningitis infection to the baby, any other sepsis, if there is history of ototoxic drugs taken, and if the baby is born prematurely. The different postnatal causes which can cause deafness in the baby, they are familial progressive sensorineural hearing loss. It can be Alport syndrome, Klippel-Feil disease, or Usher's syndrome. Or very rarely it can be delayed auditory maturation. Wire vestibular aqueduct syndrome also adds on to the above mentioned causes. Other than the congenital causes for deafness, there can be acquired causes in the form of post-meningitis deafness, neonatal jaundice, viral infection to the baby in the form of mumps or measles. Some neurodegenerative diseases can contribute in the deafness. If there is history of head trauma, or in the childhood if there is persistent otitis media with effusion. Some neoplasms also cause deafness, and at times the cause for deafness can be idiopathic, where we don't know or any other above mentioned causes are not present in the baby. The different causes for conductive deafness, they are anomalies of the outer and the middle ear. It can be in the Down syndrome associated with teacher scrolling syndrome. If the babies have cleft palate, if in the infancy there is chronic secretory otitis media, ossicular fixation, and osteogenesis imperfecta, there are other causes just to enumerate for the conductive deafness. So, while taking the history, it starts from the mother, whether the mother is suffering from any maternal infection in the form of TORCH. It should be inquired correctly. If there is any use of ototoxic drugs taken by the mother for any disorder, what was the mode of delivery, whether it was a prolonged, difficult labor, postnatal history of the baby just after birth. If the baby is found to have some ENT symptoms, or if the child is failing to develop normal speech, or if there are delayed milestones of development, which can be diagnosed by the general practitioner and especially the pediatricians. When the baby is taken for immunization to the pediatricians can diagnose these. And then they can refer the babies for specific diagnosis to the ENT surgeons. And if there is any history of deafness in the family, so all these points should be inquired in detail while taking history. So at different stages, how the baby's hearing develops. A very newborn baby gets aroused by a sound at 90 decibel. When the baby is 3 to 4 months old, the baby turns his or her head towards noise or sound of 60 decibel. At 4 to 7 months of life, the baby turns head to 40 decibel sound at eye level. From 9 to 10 months onwards, the baby can locate the sound at 40 decibel and below. From 9 to 13 months of age, the baby can locate the sound as low as 25 decibel. And from 16 months onwards till 20 months, the baby can locate a sound as below 25 decibel also. And from 2 years of age, the baby can locate the sound at all the angles, whether the sound is coming from any side. So, for development of normal language and speech, the critical learning period for the baby is from birth to 3 to 3.5 years of age. And if the baby is having deafness of any kind, if the baby can be diagnosed at the earliest, the efficient remedial measures can reduce the disability in the form of mutism till the age of 3 years. Early intervention can prevent the disability to the baby. That's why a hearing impairment should be identified at the earliest and corrected at least, if not before 6 months of age, at least first year of age. Because from first year of age, the baby starts communicating with the environment, with the members around the baby. And the auditory centers also start developing from first year onwards. That crucial period is, you can take it from 6 months of age till 1 to 1.5 year of age. That's why I'm always giving weightage to this age group, because if the hearing impairment can be diagnosed during this period, crucial period of life, the baby's handicapness can be reduced. So different screening methods to diagnose that the baby is suffering from any kind of deafness. The tests done for screening in the early infancy, they are the otoacoustic emissions and BERA, brain evoked. The other tests, they are the behavioral audiometry, conditioning tests, and objective audiometry. These all can be done in small children. So the different screening tests which are used in the neonatal hearing screening program, we all know that the government is running a universal neonatal hearing screening program. It is run by the central government and by the state governments in every state. Not only the universal neonatal hearing screening program, there is also a high-risk neonatal hearing screening program. These screening tests employed under these screening programs, they are the evoked otoacoustic emissions, which can be done as early as within 48 hours of the birth. Then the neonates can undergo BERA testing. If the babies are admitted for any cause in NICUs, the distraction test can be conducted from the 8 months of life, and the automatic test also can be taken care when the baby goes to school. A high risk register is maintained by the government. Under this high risk, the babies come, those babies born to high risk mothers, when the mother is having history of torch infection, when the mother is having history of taken ototoxic drugs during pregnancy, if there is excessive intake of alcohol during pregnancy, if the labor was hazardous or prolonged, if the baby is born with low birth weight, Apgar score, if it is below 4 at first minute or if it is below 6 at fifth minute. If the baby is admitted to NICU for any indication, then if there is recognizable syndrome present at birth, If associated craniofacial anomalies are present at both, if there is definite positive family history of sensory neural hearing loss, and last but not the least, if the babies are born out of consanguineous marriages. So all these above mentioned causes, they come under high risk babies. So if not general babies, but at least if these high risk babies can be screened at the earliest, we can prevent further handicapness of the babies. Now I'll talk something about the autocaustic emission test. The EVOC autocaustic emission test can be done at the as early as 48 hours of birth. If OAE is negative, you can repeat it after 10 days. The EAC, extra-aortic canal, should be clean. And if after second OAE also, if it comes negative or REF4, then the BERA should be performed on the baby. And if BERA comes normal, then we can suspect that the baby is having middle ear pathology. It is not sensory neural hearing. Then the baby should undergo tympanometry test. And the babies listed under high risk causes, these babies should be reassessed after every 4 months. They can be again undergo for OAE at 8 months of age, 12 months of age, 24 months of age. And BERA if the OAE comes negative. So in the infant, how to diagnose that the baby is having deafness, partial or total. So different techniques, they are adopted by the audiologist to do the hearing test. They are the distraction test, visual reinforcements audiometry, free field audiometry, conditioning audiometry, and speech audiometry. The distraction test can be conducted from 8 months onward. These are done in a soundproof environment. The child turns his head to locate the sound, and this can come positive from 6 months of age to 18 months of age. The child should be seated comfortably in the mother's lap. The assistant distracts the child with the help of a sound. It produces sound from behind the child. The sound is given only for 10 seconds, and the intensity of the sound should be at least about 35 decibels. For example, a high frequency rattle can also be used. Or whisper sound in the form of SSS can be used. This is how the distraction test done at the age of 6 months by the audiologist with the help of an assistant. The second screening is the free field audiometry. Again, it is based on the localization of sound by the child. It can be done in a baby of 6 months 6 months old up to 2 years of age. Now the sound used here is 50 decibel. The child is placed in the mother's lap 4 to 6 feet away from the 2 loudspeakers on each side of the baby. The baby turns the head to the side of the loudspeaker from which the sound is coming. You can lower the sound gradually. This is the way how the test is done in a normal audiological setup. The third screening test is the visual reinforcement audiometry. It is done with the help of visual stimuli which are reinforced with the sound. The response of the child is seen. The visual reinforces the pictures, they are kept above the speakers in the form of flashing light or a moving toy. And we have to reduce the habituation to the sound. because it sustains the interest in sound for long if it is given for a longer time. And after presenting the sound, the toy is moved or activated. So this is how this test is done in again audiological setup. The next screening test is the conditioning audiometry. Here the child is told to do a simple task, for example, putting a brick in the box in response to the sound. This can be done at children of age of 2 years to 5 years. Speech audiometry from the age of about 3 years to 6 years can be done. The child is asked to pick up cards on voice command, and the voice of the examiner should be lowered gradually. Repeat the words given by the examiner or point out the pictures representing the word given by the examiner. These were the subjective tests. Now the objective audiometry tests, they are the brainstem evoke response audiometry, autoacoustic emission audiometry, electrocochleography, and acoustic stapedial reflex. These are the objective tests. The brainstem evoke response audiometry is done after the child is well sedated. Both the ears are tested separately. This is done again by the audiologist. It detects the abnormality in the auditory pathway. The brainstem response to click stimuli 60 are measured at the interval of 50 milliseconds. An electrode is kept on vertex. The reference electrode is kept on the mastoid bone, and the ground electrode is kept on the forehead of the baby. The latency of the waveform, which is important, is it is noted. And the test started from 60 decibel sound, increasing or decreasing till the wave appears or disappears. Sometimes we can see the artifacts which are caused by the muscular contractions. In infants till the age of 1 year, only waves 1, 3, 5 are clearly identifiable and the latency is higher. Auditory steady-state response audiometry can be done where the frequency is specific or low frequency hearing loss can be tested with this. The transient autoacoustic emissions. These are the biological sound produced by the outer hair cells of cochlea, in our ear, that is. It is positive if the hearing is normal. It tests the cochlear function. There are two types, they are spontaneous and evoked. Under evoked autoacoustic emissions, they are again subdivided into transient and distortion. The OAE will be absent if the hearing loss is more than 30 decibel. Distortion product emissions are absent if the loss is more than 50 decibel, and they are negative if there is inner or outer middle ear pathology is present. Electrocochleography is done to see whether the cochlear nerve action potential is present or not. It is an invasive procedure. It requires general anesthesia, and the action potential threshold closely matches with the pure tone threshold given. The electrodes are placed around the ear, and threshold measure is between 1000 to 8000 Hertz. Impedance audiometry, again, it is the objective audiometry. Here the acoustic reflex is tested. The stapedius muscle contracts reflexively to the sound of 70 to 100 decibel. It is absent in case of middle ear pathologies if there is retrocochlear hearing loss, if there is profound sensory neural hearing loss. And this can be again done in a difficult child. And impedance audiometry can be done to see the compliance of the middle ear or to rule out the conductive hearing loss in the child. After screening for deafness, we need to do certain tests in the form of serological test for torch screening from the mother, a complete blood picture of the baby, routine urine analysis, perchlorate challenging test, and imaging in the form of MRI of the brain to see the central nervous system abnormalities, HRCT of the temporal bone, and some chromosomal studies to find out the cause of the deafness. Now, the management will depend on the cause found by these different investigations. First of all, the parent should be counseled. Sometimes the baby may be helped with the help of hearing aids. If the hearing aids are not, then a baby can be a candidate for cochlear implantation. If there are associated congenital malformations, surgical correction of some of the congenital malformations can be taken care of. And then the baby can be taught to learn the language and speech, proper education in special school or a normal school if the baby's hearing is helped by hearing aid or cochlear implantation, and vocational guidance can be given to the babies. Hearing aids are just to help in amplification of the sound. Hearing aids can be given as early as 16 weeks of age. They need aftercare. There are different types of hearing aid. Behind the ear hearing aids with soft molds can be used in babies. And as the child grows, they can be replaced. In older children, in the canal, aids can be used. And bone anchored hearing aids also can be used as per the need of the child. Cochlear implantation. Actually, ideal age for cochlear implantation, if the baby is found to be a candidacy for cochlear implantation, it used to be 18 months to 24 months, but now we have reduced the age as early as 6 months of age of the baby. If the baby is found to have profound sensory neural hearing loss, if the speech discrimination score is below 60%, that is very poor. If there is bilateral deafness, profound or severe, and if there is minimal or no benefit from the hearing aids after giving trials, and the baby is not having any congenital or structural anomalies of the inner ear or the brain, the baby is a candidate for cochlear implantation. Surgical management of associated anomalies in the form of plastic reconstruction of the pinna and canalplasty. The baby can be taught to communicate by oral methods as lip reading, gestures, facial expressions, manual communication with the help of sign language and finger spellings, and total communication with the help of auditory, visual, and tactile. Auditory training can be taken by the speech language pathologist or the spatial speech pathologist. And the training is given to concentrate on the speech sounds present in the environment. Here I want to suggest about one good model for screening and diagnosing the babies, not only in the big cities, but the small towns and periphery as remote as the villages or the small towns. I labeled it as the hub and spike model of screening of deafness by OAE. OAE, otoacoustic emissions, it is a biological phenomenon generated in the normal cochlea when the cochlea processes incoming impulse or sound, and the biological activities takes place in the outer hair cells before the inner hair cells transduce this into action potential to stimulate the auditory nerve. And the biomechanical activity in outer hair cells generates acoustic energy, which is recorded by the microphone placed in the extra-aortic canal. And it can be measured in the form of decibels. OA today provides us a non-invasive, simplest method of screening of auditory function. You can use this method in your institutes to screen the high-risk neonates at least, and then you can collect this data from your hospital and other centers, and then this data can be transferred to the higher centers by telemedicine platform, that is via online portal. And I know we all can expand this program and cover the most of the children as possible in the different maternity and child centers at the periphery, so that more and more babies can be screened as early as possible and sent for the further effective management to the highest centers. So today's take-home message is early diagnosis of hearing impairment is very, very important, because if we can diagnose it earlier, we can do the treatment promptly and we can prevent the further disability to the child. Thank you so much.
Did you find this session insightful? Do let us know by commenting below. On behalf of DocPlexus, I would like to thank Dr. Naina for her expert discussions. Dear audience, thank you for joining us today. Stay tuned for our next session. Thank you and have a great evening ahead.